Welcome to the Athletes First Performance Podcast, where two performance-minded physical therapists break down the evidence to improve overall health, movement, and performance for athletes and active individuals.
All right, episode 15 of the Athletes First Performance Podcast, and today we'll be talking about bone stress injuries in athletes. We'll go ahead and get right into it by defining what a bone stress injury is. And it is considered the inability of bone to withstand repetitive mechanical loading, which results in structural fatigue and localized bone pain and tenderness. They typically occur on a spectrum beginning with a stress reaction, which then can turn into a stress fracture and then possibly turn into a complete bone fracture if not identified and treated early. They also can be classified into low risk and high risk, but we'll talk about that a little bit later in the podcast. James, you want to go ahead and get started with the pathophysiology of bone stress injury?
Yeah, for sure. So just like you said, bone stress injuries are the imbalance between load-induced microdamage formation and its removal. So in terms of bone healing and some of the histology behind bone remodeling, we can talk about first the targeted remodeling. So this is where there's bone resorbing osteoclasts that go in and remove the damaged bone, and then the osteoblasts come in and fill in with new bone. So you can think of osteoclast with the C as cleanup and osteoblast, B as in build. So what's interesting is it takes about 4 weeks for the osteoclast to come in and actually remove the bone, but then it can take up to 3 months for the osteoblast to come in and lay down new bone. And this is where bone stress injuries come from, is too much loading in a short period of time, where you don't give your body and those osteoblasts enough time to build up the new layers of bone. And some people might ask, well, if it takes 4 weeks to remove the bone and 3 months to lay it down, why doesn't everyone get a bone stress injury? Well, this occurs at different points throughout the entire bone. So the whole bone is not on the same cycle. There's just alternating cycle between those different parts of microdamage in the bone. So this is constantly occurring at different time frames at different parts of the bone. So that's the targeted remodeling. That's the longer term healing. There's a faster healing called modeling, which is where there's isolated bone formation on the bone surface itself. So just like most of us have learned in PT school, there's a periosteal callus that comes in and provides more of the scaffolding at that injury site to restore the mechanical properties of the bone faster than targeted remodeling. So you can think of the modeling as that short-term bridge and scaffolding, with the targeted remodeling as more of that long-term bony turnover. Any questions on that? I know for people that haven't taken histology, that might be a little bit new, but I thought that was important just to get into some of the background information of how bones heal itself.
No, I think talking about the two different types of target remodeling and modeling as far as healing goes, and mentioning that despite target remodeling taking a long time, there are other ways that the bone can restructure to help it withstand the loads that it's being exposed to. And then also a little, osteoclast, osteoblast, as far as cleanup and build, is helpful to remember. So no, I think that was good. It can be a little bit confusing. I know when I read it in the articles that we used to prepare for this, it was a little confusing. It took me time to read over it multiple times to get it, but no, that's helpful. So if we get into how common these bone stress injuries are, a lot of the stuff that we read was based off of endurance athletes, which makes sense. They're going to have a higher risk based on the repetitive loading that they have, but also sprinters too. So I'll just read out a couple stats just to give people an idea. So about 1/3 to 2/3 of cross-country runners will have a history of a bone stress injury. And half of track and field athletes will also report a history. So that's going to include long distance runners and sprinters. 10.3 to 12.6% of cross country and track and field athletes with a history of BSI will sustain another BSI. So just when we get down into risk factors a little bit later, the fact that you had a bone stress injury once, you may be predisposed to another one, which is common in a lot of other injuries that we see. Having the injury before can predispose you to having it again. Interestingly, long distance runners will typically have bone stress injuries in the long bones, possibly due to their foot strike. Obviously, not everyone has the same foot strike, but a rear foot strike can increase the load to the longer bones, whereas sprinters typically are going to be a forefoot strike, and you may see bone stress injuries in the bones of the feet as opposed to the long bones. Anything else you'd like to add to the epidemiology of BSIs?
No, I like it. And I think it is good to understand. So if you're dealing with an athlete that's more of that long distance runner, you can know what to look for versus more of those sprinters that spending more time on the ball, their foot, having more likelihood of having the foot or the metatarsal injuries. Same thing with basketball players too. They spend a lot of time jumping and spending a lot of time on the front of their foot. So just looking at the NBA, there's a lot of issues with fifth met and just overall foot injuries in general. I know you've spent a lot more time in this world than me personally, like in your background of running and cross country. Did you see this when you were in high school and college? Did you have a lot of friends or teammates that were dealing with stress injuries?
I had one teammate in high school, particularly, that did struggle with uh, stress fractures. He was one of our faster guys, but um, I don't really know. I mean, he wasn't any I mean, we were all pretty small, and we didn't really do any strength training except for like push-ups and crunches. But um, he didn't really have. I mean, I didn't know his personal factors as far as like dietary intake and things like that. But um, he didn't have anything obvious to me that would have predisposed him to stress fractures. I mean, like, I wasn't looking at how he was running or things like that, but um, he was just having recurrent issues. So that fact of having, once you have one, you're predisposed to having more. Um, I think that's probably what I saw to be the most common, as opposed to, him presenting with any other risk factors. But, that was what, like 10, 12 years ago. So I don't really remember, but yeah, I definitely see it. And I saw it a lot too. And you probably are now. When I did the rotation in the military, a lot of those, and we'll talk about this as a risk factor, but changing the training abruptly. So a lot of the kids were not well conditioned for what training was going to ask of them. And probably the most common injury that they came into sick call for was for um, ended up being bone stress injuries. So, yeah, very common. I assume that you're seeing a lot of that too at this point.
Definitely. That's again, sick call after a long ruck or a run. That's probably the most common injury that we're seeing, foot or shin pain. And not all of them are stress reactions or stress fractures. Some could be on the spectrum of like shin splints, but overall, it's just high workloads without building up that training. So, getting into some of the risk factors, bone stress injuries are all training errors. So, one of the biggest things that we can think of in terms of modifying the load applied to the bone is having a proper training program. So, in some of the papers that we looked at, that acute to chronic workload ratio. So large changes in training without a proper buildup. So a lot of work in a short period of time without building up to that workload. So there can be increases in running speed, so increasing the magnitude of the stress on the bone. There can be increases in duration, so increase in loading of the bone through different cycles with longer runs, longer rucks, things like that. And just like you said, with a lot of these younger military recruits, we're seeing that they don't have a history of physical activity or training, and they're thrown into this situation where they're having to do high volume, high intensity loading, either rucking or running, that they have not prepared for. So that's where we're seeing a lot of these issues.
Yeah, and a couple other things, like you said, changes are really the big thing. And when you're talking to someone, who may have, really with any injury, but if we're, obviously focusing on BSIs, any major change. And I actually had a runner in clinic last week who, he ended up having patellar tendinopathy, but just kind of keep an eye out for anything as far as bone stress injuries. And I was asking him, like, have you changed anything in your training for this to just spontaneously pop up? And he had said he finally like kind of thought through it and remembered that he had started running with his wife, who runs at a slower pace than he does. and he noticed that his vertical excursion as far as how he was running was increasing because he was essentially traveling the distance, but he was doing it vertically as opposed to horizontally because he was having to go slower. Not that for him was a bone stress injury issue, but things like that could definitely increase your chances because your ground reaction force is going to go up. So even the little things, just like gait training, if you've changed that stuff, it could possibly increase the risk. And then other things like if your running surface changes, there's mixed reviews on whether you're running on like a harder surface versus a soft surface, whether one of those can predispose you to injury over the other. But the primary thing is just change too quickly. And then same thing goes with shoes and inserts. I don't think this is as popular as it used to be, but a lot of people were switching to more minimalist shoes back when that Born to Run book came out, or the Vibrams, things like that. And if you're switching too quickly, you could start to notice injury. So just a big change is kind of the biggest thing that you should look for when you're taking their history.
Definitely. And going on some of those topics that you mentioned, shoe wear, we work with a lot of younger soldiers that have been wearing the same shoes for over a year and they're all worn out. Their feet are hanging over their shoe and they come in with foot or shin pain. And that one of the first things we ask them is, look at your shoes. What do you think of those? Like, oh yeah, I know. I don't want to change them. I don't want to go buy them, but that's going to be super important, right? So a lot of times I tell people, okay, we're going to hold off on some of the running, but we're not going to let you run until you go get new shoes because we're not going to put you back out there with those worn and beat up shoes that aren't doing anything for you. So I know a lot of the shoe wear and the research on that is kind of mixed. I'm not sure if you've seen anything on like the right type of shoe wear for the person decreases risk of injury, but just having adequate shoes is definitely going to be a lot more helpful than shoes that are worn out and broken.
I typically, as far as shoe wear goes, you want something that's just comfortable. I know there was some research out there that said, like you said, older shoes or more worn out shoes can put, and this was in military recruits, can put them at a higher risk for BSI, possibly due to the lack of cushioning at that point. So I don't know if that necessarily means like more cushioned shoes would improve, I guess, prevent you from having BSIs. I don't think that's clear, but definitely not worn out shoes. As far as a couple other factors that I think would play a role in preventing you from having a BSI is muscle factor. So muscles are going to help attenuate loads when you're running or rucking or whatever you're doing. So if you have, just generally poor muscle size or decreased muscle size and strength, you may start to see a increase in your BSI susceptibility. And then the other piece we haven't touched on in regards to things that you can change that would modify the load applied to the bone is faulty mechanics. So just like I talked about with that guy I saw last week, abnormal forces, so high ground reaction force loading rates. And then you may see general like static or dynamic abnormal motions. So static abnormal motions would essentially be what the patient presents as far as their mobility or their foot, like high arches in runners that are going to have a reduced joint excursion and a higher stiffness. A couple of the other ones were increased hip external rotation, which wasn't clear to me as to why, and you may have a good idea of why that would increase your risk of BSI. And then leg length discrepancy makes sense, right? A longer leg's it's gonna have more force to it as opposed to the shorter leg, or I guess vice versa, depending on how you're landing. And then pes planus and pes cavus. And then as far as dynamic abnormal motions, you may see a greater peak hip adduction, knee internal rotation, and peak rear foot eversion. You also may see less knee flexion in the sagittal plane, which is going to be more of a stiffer landing. I will touch on strengthening later on in the treatment section, but anything to add with those two risk factors?
So some of the biomechanics that you pointed out, increased or excessive hip external rotation, that is something that I've been noticing after reading this. Just a lot of the people that I'm working with that have foot or shin pain for some reason they have like 50, 60 degrees of hip external rotation. Their hip internal rotation isn't bad, but they just have excessive hip external rotation.
Yeah, I can't. I mean, it's. I guess if you are doing their examination and you find that, yeah, um, I can't think of a good reason why. The other reasons make sense, but there's a couple other risk factors too. And I know you, and this makes complete sense. And I know it's something that I'll let you touch on a little bit more. But what, in regards to like physical activity history, could dispose you to more of a risk of BSI?
We know that athletes with history of playing multi-directional sports, team sports such as basketball, football, soccer, where they're continuously jumping, landing, changing of direction, loads bones at high forces and high intensities in multiple different directions. So the bone is just getting that continued high intensity stimulus, which is in fact going to increase to bigger bone size and strength. And that's not something that we can get after athletes or people are done growing. So once people hit 15, 16 years old, that window of opportunity to increase their bone health is gone. So after that, it's more about managing load. But with younger athletes, it's important to get them that stimulus. So we can talk about sport specialization. So we know that for any sport, competing in a specific sport and specializing in a sport more than 8 months out of the year is going to lead to greater overuse. We see this in baseball, we see this in hockey. Same thing with long distance and cross country runners. So we need to make sure that during that pubertal and prepubertal age, we're exposing our younger athletes to different sports and different loading. So not even just running, but specializing in sports with like swimming and cycling is not going to set these athletes up for long-term bone health in the future. So it's okay to specialize in swimming and get really good at swimming, but make sure that they're going out and playing soccer or softball or baseball, things like that, where they're getting that load through their lower body.
Yeah, I think we know with a lot of the higher level athletes that we see in like professional or college sports today, they typically have a background of playing multiple sports, right? And I know with a lot of the runners that I competed with, they kind of had a background of like playing soccer, so still an endurance sport, but also multi-direction, uh, I guess, qualities. The one thing I wanted to point out, though, yeah, we have that window of opportunity during the growing years as far as um, trying to increase bone tolerance, I guess. But that doesn't mean you still can't increase bone strength after that. It's just you're able to just set yourself up in a better position at those growing years in regards to bone strength. A couple of the other risk factors that we just haven't talked about, and one of the most important ones, and you see this in females primarily, but not to say you can't see it in males too, would be energy availability. So that's where you start to see the female athlete triad, which is a relationship between energy availability, menstrual function, and bone mass. Typically, low energy availability is the primary issue. And that's going to be caused by it's caused by an insufficient dietary intake, but it could be due to two reasons. One, you're basically out exercising your consumption, or two, you're purposely limiting your intake, and that could be for a variety of reasons. But I know there could be a bit of a body image issue for females when they're in runners. And then as far as the menstrual cycle issue, and there's way smarter people that have experienced this than me, so I hope I'm not messing this up, but you will see, particularly professionals, but really any long distance runner, because they're obviously going to have low body fat, you may see a lack of a menstrual cycle. So those things can play an issue. It can be particularly male to female, a difficult question to ask, particularly a younger female, but definitely things that you should keep an eye out. Even just observing their size. I think it was like BMI below 19, I think, was predisposed you to a higher risk of BSI. Anything else to add to that?
No, you hit the nail on the head there. And then some of these female athletes that are competing in sports that may consider body image a little bit more, like dance or cheerleading or gymnastics. Some of those athletes are again at a higher risk of the female athlete triad or the red S, just because of the nature of their sport, unfortunately. So that's where it's important to have sports psych or mental performance coaches within your ring of professionals that you can refer to. And same thing with sports dietitians or registered dietitians, making sure that the athlete is on board with proper consumption and nutrition.
Yeah, then the dietitian piece, particularly with calcium and vitamin D intake, just something that we saw in the papers with that women who consumed less than 800 milligrams of calcium per day had a 6-time increased risk of bone stress injury compared to those who consumed 1,500 milligrams a day. And you're just trying to ensure calcium and vitamin D intake would exceed the current dietary allowances just based on what their body will require. So yeah, all things to keep in mind. PT, some of these things are going to be out of our scope of practice, but like you said, having a wealth of providers around you that you can refer to can be extremely helpful in managing them and then ideally preventing another one from occurring. Did we touch on everything in risk factors? I feel like that was pretty good.
Yeah, I think we covered a lot of it. And one more thing about the vitamin D and the calcium, as PTs keep on getting more autonomy with ordering labs and imaging, making sure with athletes that you're suspecting of any type of bone stress injury, you're taking a look at those vitamin D labs. So having the athlete make sure that their doctor is ordering that, or if the PT is able to do that in their setting, ordering that as well. So that's an easy thing that you can fix with supplementation and diet, nutrition, and lifestyle, but making sure that everything's on board with that.
Yeah, no, totally. I think definitely having awareness of that, but then also, having the awareness that there are providers that are much better at looking at stuff than us. So
Yeah.
noticing it and then referring out if you need to. So yeah, let's move into clinical diagnosis. And there's a bit of I guess I kind of had it broken down into 3 different stages, and it all surrounds pain level. I would like to mention that you can get an image of I think they were talking about primarily long distance runners that may show something similar to a bone stress injury, but they followed them over 2 years and they still had no changing in what the bone looked like. So one of those things where imaging doesn't tell the whole story, so that there needs to be pain present. So in the beginning, you're going to have a mild diffuse ache. And the pain is going to differentiate between like a tendon type issue where it's not going to warm up and get better as you perform that activity. And then it should cease at rest. So that's going to be a defining aspect of a BSI. As the BSI progresses, the pain will become more severe and then localized. And it may start to persist longer after the aggravating activity. And you may even start to see it with lower levels of activity, such as like walking or something like that. And then as it advances, you may start to see pain at rest or having night pain. So that's kind of a general overlook of the beginning stages to advanced stages, not looking at the actual physical exam. Is there anything else that you would look into as far as the just, I guess, report of symptoms?
Yeah, so you did a good job explaining that. And I think it's important for people to understand that with tendons and muscles, we're okay with working into a little bit of pain, but with these bone stress injuries, we want everything to be pretty much pain-free as we keep on loading and progressing them. So that's something to look out for. And in terms of the local bony like tenderness, you can also see a little bit of like either redness, swelling, warmth, just showing an inflammatory reaction. So I actually saw someone or at the end of last week, he had just got done with a 4-mile run, probably within the past week. And he was having a sharp pain in the distal third of his tibia with every step. And you could see there was just that local tenderness. And he actually had like loss of definition of his tibia, which is swelling and redness. So that was something that definitely was easy to pick out. And it's like, okay, we need to think about having this further manage in terms of bone stress injury. So those are just some quick tips. In terms of bone loading tests, there's a couple of them. So we know that the fulcrum test has a pretty good sensitivity for hip stress fractures, hopping, so single leg hopping or double leg jumping, reproducing pain. And even for like the spine, like the single leg hyperextension. So going into spinal extension can increase stress on anything like a spondy. So those are a lot of our tests outside of just the local bony tenderness. There, I have seen some things and seen people use like tuning forks or ultrasound to help diagnose stress fractures, but that hasn't really been supported in the research. Have you used any of
Yeah,
those?
no, not the tuning fork or ultrasound or anything like that. And honestly, I mean, yeah, so the tests are there. I think that primarily you're going to use history and palpation. Um, I think those are I mean, I don't do a lot of special tests anyway, really on anything. But yeah, history and palpation are probably your go-tos. But yeah, I mean, I have done some hopping and things like that to see if that reproduces symptoms for sure, by just essentially reproducing the aggravating factor. So yes, and I'd like to hear the process on what y'all are doing at work. But I mean, the typical process is going to be if you suspect a bone stress injury, imaging is going to be required, and typically radiographs are going to be the first line of imaging. There is, you can do a bone scan. It has poor specificity, but if you don't see anything on there, you can rule out a bone stress injury. But you're getting high levels of radiation with that. So from what we read, MRI seems to be the best imaging choice. It has a high sensitivity and specificity, and it should provide the best just visualization of the bone stress injury. Now I'll go into what they did at Fort Jackson when I was there, and if anyone came in, if a recruit or came in and they said they had hip pain, they immediately were put on crutches, or groin pain, I guess, or hip pain in general. Yeah, they're immediately put on crutches because of the likelihood of a stress fracture is high, and because of the high risk of a femoral neck stress fracture. And then they were sent for radiographs and bone scans. If it was shown that they had one, then they were basically put on bed rest to a degree, non-weight bearing. I mean, we can talk about that a little bit later. But what do y'all do? What's the protocol if someone comes in and y'all suspect a bone stress injury?
Yeah, I haven't seen too many of the hip stress fractures. Most of what we're seeing is shin and foot. So again, kind of like the same thing. We're going for X-rays and imaging if we're suspecting bone stress injury, and it depends on their ability to load. So if they're only having pain with running and jumping, we're just having them hold off on running and jumping. We're letting them walk, no boot, no crutches. But if someone's having that sharp pain, they can't walk for more than 10, 15 minutes without getting that pain, then we'll start thinking about unloading them with crutches or a boot. And with the tibial stress fractures, if it's pretty acute, we're not going to be able to see it on x-rays. So that's only going to be if there's that fracture line. So again, like you said, having the bone scan or the MRI is going to be a little bit more specific to having that pop up in terms of stress reaction or stress fracture. But with the low risk tibial metatarsal, we're not overly aggressive, but we will go and get x-rays and appropriate imaging if they're having a hard time loading with ADLs.
Yeah, so if we do move into the categories of high risk and low risk stress fractures, once it's known that they have one, I'll just list out the low risk and high risk, and then we can talk about the definitions of them and how you would treat them. So high risk stress fractures are going to occur on the tension side of the bone's bending axis. So you're looking at femoral neck, the anterior tibia, medial malleolus, talus, navicular, the fifth met, second metatarsal, and even the sesamoids. And then low risk is going to occur on the compression side of the bone, bending axis, and you're looking at the posterior medial tibia, lateral malleolus, femoral shaft, pelvis, calcaneus, and the second to fourth metatarsals. They also can divide them up once they see them on imaging as a low grade versus high grade. And there's definitions of those in the research, but just in general, the purpose of those generally is to help determine recovery time. On average, a high grade bone stress injury may take on 20 weeks to get better, whereas a low grade could take 8 to 9 weeks. So yeah, it's important to know the location, and the management will follow based on location and the grade of bone stress injuries.
Yeah, definitely. And just having an understanding of what's low risk versus high risk. So, like you were saying with the hip, that's more of a high risk site. So, that's going to take a little bit more precautionary measures versus some of the low risk that you can manage with more load management and activity modification versus having to get the quick medical management.
Yeah. So, if you want to move into treatment.
Yeah, so some just overarching management of, we're going to focus on low risk bone stress injuries throughout the rest of this, but some of the overall arching themes that we want to think about are going into the training history. So reviewing the history of the athlete and the runner in terms of what they've done in the past, what they've done leading up to this specific injury that they're coming to see us for, and where they want to be able to get to if they're training for a specific goal. Making sure that we're talking on diet, nutrition, possible gait analysis. So if they're coming in with running related pain and possible stress fracture, we're probably not going to have them run the first day, but if they have videos of them running, we can take a look at that. And then eventually, as they get back into their running program, obviously taking a look at their gait. We've already talked about the shoe wear pattern, history of overuse injuries, so tendon muscle and or previous bone stress injury. Specific single leg strength and mechanics. So things like single leg squat, wide balance. So making sure that they have appropriate strength and stability on one leg. And then also looking at more of their trunk stability, their lower body endurance, and their foot intrinsic strength. So those are the main things that I'm thinking of when going into treatment for the lower body bone stress injuries.
Yeah, I think if I just kind of put those in order, primarily first is activity modification, right? So stopping the painful activity. It's not unreasonable for a low risk bone stress injury to require possible crutches or offloading if needed. It's just dictated by the pain that they feel. And while you can't necessarily load them as far as impact activities while they're resting, yeah, that's when you would manage the risk factors. Just paying attention to the history as far as training changes, shoes inserts, and at that point you can give them just advice. Dietary education or referring out to a dietitian during that period of time can be helpful. Strength training, yeah, depending on the patient, as long as it doesn't create pain. Loading up, like you said, and then doing your best to maintain their physical conditioning, particularly as if they're a competitive athlete to some degree. They gave options as far as underwater running or the gravity eliminated treadmill, which obviously you're not going to have access to that most likely. But then just doing some like cross training, like cycling or swimming, just maintaining pain-free activities. I will just briefly mention high risk. So as far as high risk, you're non-weight bearing at that point. Depending on the location, you may be casted. Depending on the severity, you may need surgical fixation. And then as you get better, the treatment kind of flows into the low risk category as far as you can return to weight bearing when imaging shows that healing is happening and you're pain free with weight bearing and palpation. And then as you get better, you start to work into return to activity based on pain levels. If we talk about and you can add stuff to that too, but next I think it'd be good to talk about plyometrics and how they apply, and then just a bit on the return to running phase.
Yeah, definitely. But before we go into the plyometrics and return to run, are there any specific like range of motion in terms of the ankle, lower body, or specific strength factors that you want the athlete to be able to do before we even get into plyometrics or return to running? So I know something that we always take a look at is like closed kinetic chain dorsiflexion range motion, making sure they have adequate dorsiflexion, big toe range of motion, like big toe or great toe extension. And then even like single leg heel raise strength. So being able to hit a certain amount of single leg heel raises on each side before we start even thinking about progressive like plyometrics or jump training. Do you have any specific markers that you look for?
I think anything that could limit their or that could create higher ground reaction forces. So yeah, like lack of dorsiflexion, working on that. As far as strength, you're looking at like control, endurance. You're targeting the hip, knee, and the ankle. Um, like you said, strength of the intrinsic, extrinsic foot muscles, depending on if their stress fracture was in the foot. Um, but essentially, I think you're just running them through a program that would be as most specific to the sport as possible, particularly with endurance athletes. And I think it's getting better now, but younger ones for sure probably aren't getting the appropriate strength training that they could. There's absolutely no detriment to doing the strength training at this stage as long as it doesn't hurt. So, like for example, one of the risk factors of a bone stress injury was decreased knee flexion in the loading phase. So just making sure that they have the adequate strength to kind of eccentrically load the quadricep. So you can, I think tempo stuff would be great into the eccentric phase. So yeah, I think just really evaluating the athlete, seeing where their deficits are and seeing how that relates to the sport, and then treating it. I mean, if it takes, on average for a low risk or low grade stress fracture, 8 to 9 weeks to return, you have a pretty solid window of opportunity to work on strength training.
Yeah, definitely. And one thing that we kind of skipped over, but one of the things that I'm thinking of, like the main thing with the phase one of the program is just getting them with pain-free walking and ADLs. So that's really my first goal for them to be able to get off if they're needing crutches or a boot, regain that non-weight bearing control, strength, whatever we're doing in PT, to just be able to get them walking 30 minutes, an hour without having their same complaints of pain. And another thing, I'm not sure if you're having to deal with this a lot, but people using NSAIDs. So I'm making sure that they're not using NSAIDs for more than 7 days, because that definitely delays bone healing, which you know of. So also just making a quick note of that.
Yeah, and the other part with pain medication is it could mask the pain that you're feeling while you're doing activity. And because pain is the primary marker of whether you should progress or not, you don't really want to hide from it. So just being aware of that is important.
Definitely. So once they've hit those phase one goals of being able to walk, a lot of the studies showed that prior to returning to a running program, you want the athlete to be able to walk at least 30 minutes pain-free and have 5 to 7 consecutive days of no pain. I think that's pretty reasonable. Making sure that they're not having any type of reactive pain with just gradual ADLs and walking. And then I also like what we talked about at the beginning of this topic of just making sure they have adequate plantar flexion strength, range of motion, single leg control, besides just being able to walk for 30 minutes. And also in terms of getting back to run, we only want to change one aspect of their return to run program at a time. So we know that the bone stress increases exponentially with an increase of magnitude or speed of running versus more of like that one-to-one increase in bone stress with volume. So a lot of these return to run programs gradually increase volume, keeping the intensity or the speed of their running at 50%. So keeping the speed the same, increasing volume over time. And then once they can hit their specific volume, then going back and gradually increasing their speed.
Yeah, I think with that return to running program, it's important, like you said, to work on volume before intensity and working volume up to their pre-injury level of how much they're running, whatever this sport was. In that article titled "The Management and Prevention of Bone Stress Injuries in Long Distance Runners," they provide a graduated running program that's pretty comprehensive and really talks on getting volume first, maintaining intensity. So when you when you start at a baseline level intensity, it should be about 50% of the normal pace that you were running prior injury. So jogging, like conversational pace, and then you're working a walk to run ratio, and you're working repetition. So it starts off, like you said, walking for 30 minutes, and you're doing this every other day. Then walking for 9 minutes, jogging for a minute, walking for 8 minutes, jogging for 2 minutes, et cetera, to the point where you're getting comfortable jogging for 30 minutes straight. And then you start to build up the pace at 60%, 70%, 80%, 90%. You are monitoring pain level during and after. So if you start to have pain during that phase or after that phase, and you need to back off back to the previous level where you didn't have pain, and then build up again. But really focusing on walk to run initially, it's super easy to measure volume if you give times as opposed to distance, and then just monitoring pain as you go. So I recommend checking that program out as a baseline for anyone that is returned to running. And I know Chris Johnson of Zarin PT, he really advocates like run walk program when returning to running with any injury, but his stuff looks very similar to the program in this article.
Yeah, I definitely like the program. It's pretty comprehensive. And also making sure that if you're just listening and trying to follow along with the program, making sure that you're taking at least one day in between running bouts as you're increasing volume, increasing intensity. And then that last stage, that stage 3, is when you start progressing running to 2 consecutive days with the rest day on that 3rd day. So that's something that I really liked. I'm pretty familiar with the first 2 stages, but I like the idea of being able to progress the running 2 consecutive days, being able to handle that short rest break with the higher volume without, again, getting those similar complaints of pain. Do you have any recommendations? So if someone's just trying to follow a specific running program, are there like general themes that you think people should know of? I know it's pretty common of, okay, you don't want to progress something more than 10% each week, but do you have any tips or tricks for just overall programming issues that you've seen that's pretty common in runners?
I mean, I definitely think the progression too quick thing is the biggest issue. I think there's also, and it depends on the runner's physiology really, because obviously everything's individual. But there's a push towards running, and it's kind of that 80-20 running thought process where 80% of your running should be, and they base it off of like zones as far as heart rate goes, or intensity, but like very low level conversational pace, almost painfully slow. And then 20%, and you can look at this as like a weekly plan, 20% is going to be high intensity. I know when I was running more competitively, all my runs were relatively quick compared to that thought process. If like I was doing actual numbers, but I mean, it felt fine. I mean, it was work, but like all my long runs and all of that were probably unnecessarily fast. And I've tried the 80-20 running, and it is extremely slow. You get used to it, but it is extremely slow. But you still get appropriate adaptations. You're not going to lose fitness because you're running slow, but it makes those higher intensity workouts more effective because you're not taxing your body for like the other parts of the week. So yeah, I think like big changes in volume, and then probably just running too intense too often.
Yeah, and I think that brings up a good point, because this return to run program, this is not considered their cardio. So they're not doing this return to run program to improve their cardio. They're doing this to improve their tolerance to the bone loading. They can get their cardio through cross training during this phase. So assault bike, rower, skier, things like that. So just making sure that you're reminding them of the goal of this return to run program.
Yeah, no, I think that's the most important thing there. Knowing that it's more for getting the body accustomed to impact as opposed to making you faster. Okay, so we should probably move into plyometrics, which I guess would be the last topic, and how that can can improve your ability to tolerate higher loads. I think you having worked with more kind of performance population, you probably have a better handle on this than me. But I'll just generally start with just the volume or how you would program it, and then you can dive into different options, the purpose, and maybe the focus while you're doing it. But generally, this is from an article called Optimal Load for Management of Low Risk Tibial and Metatarsal Bone Stress Injuries in Runners, the science behind the clinical reasoning. And this has Stuart Warden, Brent Edwards, and Rich Willie on it. And they recommend progressively increasing the loads with plyometrics. They say that plyometric loads should exceed normal activities, especially if you're trying to adapt as far as bone strength goes. You don't need to do it like a ton of reps of it, but several times a day, at least 3 times a week. You want to go ahead and touch on options and just general focus of plyometrics?
Yeah. So taking one step back, like the plyometrics are important because of just the physiology of bone and how they adapt and react to stress. So the bones respond best to more of the higher magnitude loads that occur at higher rates, kind of like the plyometrics in the sports that we were talking about earlier. So bones like intermittent and explosive jumping, sprinting, cutting to help remodel. When we look at the bone cells adaptation to running, a lot of these papers say that the bones become deaf to the loading. So after 20 repetitive cycles of just the same jogging or running, the bone doesn't adapt to that. So that's why we want to supplement the bone loading strategies with more of these plyometrics. And just like you said, you want to do this several times a day. So if someone is on their walk to run program and they're progressing through that, they're not getting more than 20 cycles of bone loading just because the bone doesn't respond to it. So after 4 to 8 hours of bone loading, over 90% of the mechanosensitivity is restored for the bone. So that's why those shorter bouts of high intensity loading is going to be more, or the bone's going to be more receptive to that versus prolonged long duration loading, which is where these plyometrics really come in. So a lot of the options for plyometrics that were in this paper, obviously there's a plethora of different plyometrics, but a lot of the things that they came up with were like a max vertical jump, a counter movement jump, forward like long jumps, box jumps, lateral jumps, split jumps, and any type of single leg hopping. So it's really not the impact of the jumping that's loading the bone. It's more of the muscle, the dynamic and high intensity muscle force pulling on the bone that's helping the bone remodel and load. So if you can just add in what they said was 40 seconds on, 20 seconds off of these different types of plyometrics and jump training, that's going to help the bone respond a lot better than the long cyclical loading of running or jogging.
Yeah, and like you said, it's less of the impact, more on the muscle force that's going towards the bone. So they recommend focusing on explosive takeoffs rather than like a heavy impact with landing, which I guess I honestly, I mean, that was relatively new to me. It's just an important point, but not something that I would have. Obviously, you're exploding up to jump, but not something I necessarily would have thought that would be the focus over like the impact portion of the plyometric.
Yeah, I definitely like that. And this paper was great, just exposing some of these things that I wasn't really thinking of. And even if the athlete isn't ready for actual jumping, like they can't handle the plyometric part, just fast power movements like kettlebell swings or dynamic squats or lunges with band resistance, where they're not actually leaving the ground, but they're moving fast and explosively, will help remodel the bone according to what we're reading here without actually having that impact where they can't handle it quite yet. So just something to think about in terms of the speeds of loading with strength training and plyometrics.
Yeah, and we talk about how strength training and plyometrics will help just overall bone strength and prevent the possibility of having a bone stress injury. But it's also, and maybe the best way to sell this to some of these athletes is it's going to increase performance, particularly as just a different stimulus. Thinking of endurance athletes, So it's just and we know this, there's just a multitude of benefits of strength training and plyometrics and trying to improve power with these athletes that typically are primarily endurance based.
Yeah, definitely. So last thing I really have here, you can let me know if you have anything else, but in terms of periodization, so the one of the sections of the articles was called periodization to build more bone. I thought it was pretty interesting where they looked at two groups. So one group was continuous loading and running for 15 weeks versus a periodized group with 5 weeks of running, 5 weeks off, and then 5 weeks on of running. So one group had 15 weeks of total work, one group had 10 total weeks. And the group that had that 5 week off period actually demonstrated greater bone adaptation. So I thought that was pretty interesting and definitely can play a role in how we program running and strength training in these athletes. So it's important to make sure that you're programming deload weeks throughout a training program and not just hammering these athletes with prolonged 16, 24-week programs where they don't really get much of a break.
I would assume that's based on that target remodeling pathophysiology, I'd imagine.
Mm-hmm, definitely. Do you have any experience with that? Like I'm not much of a long distance runner, but with your programs, did they give you like a rest break every 3 weeks or every 6 weeks?
No, I think we survived off the resilience of someone who was young. We were doing we'd have our long run on Sundays. We typically race on Saturday, and I think we had like two hard workouts each week on Monday and Thursday, and then all of our slow runs were probably too fast. So maybe that was why that kid got stress issues.
Yeah, I could imagine.
When so yeah, we and then like our strength training was like literally push-ups and 150 crunches. So yeah, the fact that we were relatively competitive based off that was probably just pure survival. But yeah, I don't know. It worked. We were young. I don't think that is probably the most effective training program. I think we know that, probably knew that then and definitely know that now, but what are you going to do?
Yeah, and I'm sure a lot of high school and middle school athletes are still being run into the ground just like that. So hopefully, as people keep on reading the research and getting out there, just programming a lot smarter. I know with strength training, it's the same thing. Usually there's like a 4 week block with 3 weeks of progressive loading and then a deload week. So hopefully that will keep on getting into the running world to where these athletes get a deload week or like a cross training week where they're not repetitively running.
Yeah. I think the more dialed in your training program can be, the better the athlete will be. And I think just, even if whether you're a PT or a doctor or just a coach, not just a coach, being aware of, the possible signs and symptoms of a stress injury and referring to the appropriate providers is important just for the short term and the long term benefit of the athlete.
So wrapping this up, who would you say are your top follows, or if someone's looking to get into bone stress injury research or learn more about running program, who would you say are the best people that you followed or take a look at in terms of getting more knowledge in this topic?
Yeah, typically take a lot of the this is for runners in general, from Chris Johnson, Nathan Carlson, and Rich Willie. The two of the papers that we focused on for this podcast had Stuart Warden in it, which is someone who I wasn't familiar with, but someone to keep an eye on. So those would be, I guess, mine. There was a podcast with the Runner Zone, which is Chris Johnston, Nathan Carlson, who they had Rich Willie on. They talked about patellofemoral pain, but they also talked about stress fractures. And Rich gave kind of his short and sweet big things to work on, which is things that we touched on in here, as far as preventing bone stress injuries as a youth and just in general. So those are mine. How about you?
Yeah, same thing. Whenever I have a question running related, I just ask you. So if you're getting those, if you're using those resources, those are the same resources I'm using. So anything else that you can think of, or are we good to wrap it up?
I think we're good.
All right. Well, thanks everyone for listening to Athletes First Performance Podcast. If you have any questions about this topic or future topics, just make sure to let us know. See you in a couple weeks.
See you.
Thanks for listening to the Athletes First Performance Podcast. If you have any questions regarding this episode or future episodes, please be sure to reach out on social media or our website. Both links can be found in the show notes.